basically, immune checkpoint inhibition has been a very, I think, revolutionary treatment paradigm that has been introduced first in solid tumors and has led to, I think, very impressive results in multiple advanced solid tumors, including lung cancer, skin cancer, head and neck cancer. And now there is a large number of FDA approvals using those immune checkpoint inhibitors for solid tumors. And I think very meaningful clinical results in terms of survival, prolongation, as well as overall clinical responses. The focus on solid oncology has initially started with the anti-CTLA-4 and anti-PD-1, PD-L1. And those were studied in myeloid malignancies. However, the responses so far have not been particularly impressive. There has been mixed results for the most part. And I think many of us have been somewhat disappointed by not seeing a very strong signal with those, I would say, conventional immune checkpoint inhibitors, largely because we think of myeloid malignancies as one of the most susceptible diseases for immune intervention, because bone marrow transplant is essentially an immune intervention, and it's the most the most potent anti-leukemia therapy we have. So I think, we recently presented the first randomized study with one of those immune checkpoint inhibitors using in the Fusion 001 study in both AML and MDS in the frontline setting using an anti-PD-L1 therapy called Magrolimab. However, there was a negative signal in that study, both in terms of responses, which were the primary endpoint, as well as the overall survival. So I think trying to move forward and try to improve on immune checkpoint inhibition in myeloid malignancies, we have realized the importance of other pathways. One of them is the TIM3. So TIM3 is basically an immune checkpoint inhibitor pathway that is not only expressed in the innate and adaptive immune cells, but it's also expressed on leukemia stem cells. And there has been preclinical data supporting inhibition of this pathway in terms of immune stimulation. And this was taken to the clinic in a phase 1 study in patients with AML and high-risk MDS. This was just presented in the American Society of Hematology, the first set of results from that study. And patients with MDS, especially in the frontline setting, high-risk MDS, achieved, I think, what I would consider a significant overall response rate in combination with decitabine in the range of 60%. I believe the complete remission rate was around 26%. So those data were appear better than what you typically would expect with decitabine monotherapy. And I think based on that success, this molecule has been taken into a number of clinical trials right now. And the stimulus program that we presented in the European Hematology Association in trials and progress kind of summarizes the different studies that are happening within this program. So I think the main two studies in MDS is a phase 2 and a phase 3 trial in which patients are being randomized to receive azacitidine or decitabine versus azacitidine or decitabine with MPG. It's a placebo-controlled double-blind study. So that's a phase 2, which is ongoing right now. The phase 3 study using the MPG453, the anti-TIM3, is basically a much bigger study as expected for a phase 3 trial, and is looking at combination of azacitidine with MPG versus azacitidine alone, again in a double-blind, multi-center, international large trial. And trying to take this inhibition of this pathway to AML, another ongoing phase 2 trial within the stimulus program is looking at older unfit patients with AML, in which patients are receiving azacitidine with venetoclax, which has become a standard of care really in the US, in combination with MPG453, to try to see whether we can improve upon the responses and the survival that you are seeing with this doublet as we go into a triplet combination. So all of those trials are ongoing or about to start, and I think I remain very hopeful that immune checkpoint inhibition will have a role to play in myeloid malignancies, and it's just a matter of figuring out the right pathway. And on that note, another, I think, interesting immune checkpoint inhibitor is Magrolimab, which is an anti-CD47. don't eat me signal, which is an immune checkpoint inhibitory pathway that applies mostly to the macrophages. In a phase 1 ongoing study that's also being reported in the European Hematology Association meeting, both for MDS and AML. I think there's good early data. However, of course, we need longer follow-up and more patients to accrue, but it does seem to me, based on those presentations, that immune checkpoint inhibition will have a way forward in the setting of myeloid malignancies.